things are not going well.
The people coming out now don't even really know that, kind of know the difference or the way things were done before.
They were never good old days.
We have been bred to be competitive and oftentimes not collaborative.
We have to feel that there's a human aspect.
And there's that dangerous middle ground.
Really only 6 to 8% of the total healthcare spend.
Everything's electronic. They can already tell who I am, what I do, what I have.
You had to get the highest scores on a board. This is our big fight.
I confess in every situation.
It's like the world against primary care.
Patients would heal much faster.
So there's a problem here, right?
And the tagline says,
I'm shocked.
we got all our venting out. There's a lot of,
I think we just
got
started.
serious really fast.
I'm shocked. I mean, where do I even begin?
Hello and welcome back to another episode of The Six. I am Dr. Donna Coriel. I'm an internist and the founder of SoMeDocs. And as always, I'm going to have each of our hosts/guests introduce themselves very succinctly, do it in one sentence. I don't know if we can do that, but all right, starting with Dr. Baumgartel over here.
I'm Dr. Susan Baumgartel, an internal medicine physician with over 30 years of clinical experience. I serve Washington State patients with medical consultation and advocacy support in my telemedicine business, My MD Advocate. I also run a free informational website, menopausemini.com, and wrote a book, same name.
All right, Franchelle Hamilton.
Hi, Dr. As she stated, Hamilton. I'm a bariatric surgeon, board certified also in obesity medicine. I am an author of 3 books, founder of NeuroSwitch Weight Loss, and definitely focus on brain and genetics to help patients lose weight.
Dr. Brian Gantworker.
Hi, Brian Gantworker, Chicago native, live in LA, board certified, complex spine fellowship trained neurosurgeon, specializing in endoscopic, minimally invasive neurosurgery and concussion. Looking forward to our final and ultimately very cool taping of this show. Thanks for having me.
Awesome. Dr. Alejandro Badia.
Hi, Alejandro, orthopedic upper limb surgeon, wrote a book, Healthcare from the Trenches, trying to fix issues like all of us are facing every day.
And Dr. Bradley Block.
Bradley Block. I'm a private practice otolaryngologist on Long Island and the podcast host of Physician's Guide to Doctoring, a podcast aimed at helping physicians be the best versions of ourselves in and out of the exam room.
Love it. Love everyone's intros. You all get an A+. Head of the class. All right. Let's go directly to our posts and shares. For those of you just tuning in, maybe it's your first time watching, we share posts from online, all kinds of different posts that generate discussions, and we discuss them. So here we go. Here's our first one. Let me stop sharing here, and I am going to say the following. Can we talk just for a few moments about why everyone in medicine should currently not be feeling okay, to warrant a graphic that says that everyone's going to be okay? And then the second part of that is, do you personally think that everything in medicine and everyone in medicine is going to be okay?
Well, I'm thinking about maybe it's how long have you been in medicine? So I've been in medicine for over 30 years and things are not going well. That's an understatement. And I feel like I'm not a Debbie Downer, but it's not going to be all okay. I think there's going to be a lot of shifts we all have to adjust to. And, I feel like I'm going to be retiring before, hiccup. There's a lot of changes that I would have to consider. It's a tough era. And then I look at people who are just finishing training. There are miles between us in terms of what we focused on and what we're able to do or what we want to do. And so I don't know, it's just like it's a big pot that's being stirred. It's complicated.
Who else are we okay in medicine? Are we not okay? And do you personally think that everything is going to be okay?
I think everything is not okay. I do think unless, as a group, physicians, especially ones who've been in practice, if we don't sort of agree on some things we need to work on and how to do it, we're not going to continue to sort of be pulled down. Not long ago, we were told that doctors' fees are the main drive of the cost of medicine, the cost of care and healthcare. And now that 80% of physicians are employed, it's obvious that was never the situation because that should have stabilized, right? So, and it hasn't, it keeps going up. So now we have, we're slowly being sort of pushed out of the role of leadership in healthcare, mainly because we cost too much and because we disagree with the corporate bean counters. And so I know a lot of people are doing direct patient care and other people have opted out. I think ultimately that might be how it has to be to survive in this sort of nuclear winter that we're going through right now. And maybe at the other side of it, we can sort of get back to business. But there's a lot of people that don't really know what they're doing, who are in charge of everything. And until that sort of reverses itself and we sort of flip the boat, so to speak, I'm thinking about the Pirates of the Caribbean. I forgot which one it is, but when they're sort of in this purgatory and then they flip around, the boat actually literally flips and they're right side up again back in the real world. So I always feel like that's kind of how we're kind of sailing upside down under the water's surface. And until we can figure out how to invert that, it's not going to get better. We're going to continue to get blamed for it, even though really it was never us to begin with. So I think everything's not okay. It's okay to not feel okay. But I really don't know how, unless we stop fighting each other and stop, trying to claw our way to the top to be kings of a pile of poop. I don't know how else we're going to fix this.
I would like to build upon what Brian just said about how did you phrase it, Brian, about us not working together. That is one of the main problems. And I'm facing a situation now in our surgery center, and my colleagues don't get it. And I'm thinking, this company's taking half of our money. The quality of the care overall is going gradually down. And most of the challenges we all face day to day have very little to do with that difficult case. As you folks know, I've had a kind of a tough day. Today was the first day we went live with a new EMR that was forced upon us. And it was like the other one was fine. They just said, well, we're not going to support it anymore. Same with my x-ray from 2 weeks ago. I just spent 170 grand on a digital. I mean, it's a top of the line machine, but I'm thinking, well, how am I going to pay for that with what reimbursements are? So the reality is that there are hard-headed people like myself, but I think that the younger people coming into medicine won't necessarily be fighters like that. And, hopefully they're going to be very good doctors. That's what, to me, is the most important thing. But we're fighting challenges that aren't even about what we used to worry about, which was a difficult case, a difficult patient. And that's why I love the prologue in my book. It's only 2 pages. If you read anything, it wasn't written by me, and it brought tears to my eyes. That is the middlemen are really what's killing medicine. And if we don't get together to have them, I'm saying we have to push them out, but to put them at a reasonable level compared to the people actually delivering care, physicians, nurses, mid-levels, technicians, then I'm not sure. So I don't think we're okay. In a way, it's kind of irrelevant, maybe for me, because I know I've already slowed down because I just don't have the moxie to fight at that level. But I'm worried about our future.
I'll jump in because I feel like I started, and probably most of us here, some more than other, but I started when it was kind of a straddle. I was still paper charts when I was in residency, actually kind of before EMR, and that seems a long time ago, but some people had already switched over, but it was still, I learned and trained with paper charts. And a lot of my attendings, when we switched to EMR that were older, they just quit because they're I'm not dealing with this. But I do think EMR was a good way to go ultimately. But I remember from a pay standpoint, so much stuff has changed. And I think there's times where I felt like physicians should have unions, like some of these other specialties, just because I feel like almost like what has been said already, we get blamed for a lot of things, a lot of the economic problems with healthcare. And yet I feel like there's no one really to kind of argue for us or fight for us, because most physicians only want the best for their patient, to be honest. They sometimes they make us feel like, oh, we want money, we're like all of these different things, we're getting kickbacks, like all of the, and it's really, we really do want what's best for our patients. And yet the payments for physicians have significantly decreased. And that's been the hardest for me, because when I came out, I was being paid as a surgeon significant, like what's being paid now has gone down from when I first came out and started practicing. And so the people coming out now don't even really know that, kind of know the difference or the way things were done before. So I almost feel like there's a group of physicians that either you already retired and you're like, forget it. But the ones of us that kind of are splitting this, it's very difficult for us to kind of see the way things were and what's kind of trend over the past 10-15 years. So I would say I don't think it's okay. I feel like in my world, especially obesity, the rates have increased, you know what I'm saying? And so there's a lot of things in healthcare that have not improved. And then a lot of the treatment, I think, of physicians has gotten worse, and not just healthcare across the board has gotten a lot of pay cuts. And I think it's becoming more almost like government has more their hand in it more. I feel like it's kind of being taken away, and that obviously we've seen that in some of the political things that happened. And so the concern is, as it shifts to having people not in the medical field tell us how to run medicine, that is very concerning for me. So that's my 2 cents.
Dr. Block?
So I think the question is it binary? Are we okay? Are we not okay? I think the answer is we're always somewhere in the middle. Sometimes we're going to be more okay. Sometimes we're going to be more not okay. I think, we can't look back at like the good old days. I think there were no good old days. That's a big farce. They were never good old days, right? Every generation has their issues, has their fight, and we've got ours, right? And so, previously they were overworked and maybe they were appreciated and respected more. But they had, they were physicians where they're still where their entire identity is wrapped up in medicine, and they could never retire and they could never quit and could never leave because they didn't know anything else. And they were trained in a much more toxic way than we were trained. So it was okay to be verbally and sometimes physically abusive, right? So those are the good old days that we're talking about. They had their issues, and now we've got our issues. And these issues that we're facing we're fighting against the vertical integration of these insurance companies that now own every aspect, including owning like the patient care, including owning us. And so this is our big fight. It's just whether we can overcome this fight or whether the healthcare system is going to implode, and who's our ally and who is not, and how are we going to do it. I don't have any of these answers. I know some people say, like, I think Brian had mentioned 80% of physicians now are employed, right? Which means that the physicians that are coming out don't know really any other way. Like, they're looking for jobs. All they see is other people being employed. And so because we've sold our practices to private equity and to hospitals and whatever, they don't see any other option other than being employed. And so now they're going to be stuck in those systems, and it's going to be impossible or near impossible for them to find their ways out. So this is our particular, our generation before us and before them had their not okay. I think this is and it seems to be that we're all saying the same thing. The corporatization of it and the commodification of us is we're not okay.
I want to comment on what Brad said, because ironically, even though this has been a tumultuous week in many ways, ironically, I have my first partner in 15 years because I had been with a big hand group, and he actually has a different outlook. It was tough to find somebody like him, but I will tell you that maybe there is some hope, because I'm solo private practice. He's going to end up with it, so I think it was a good move for him. But there are people like him who, and I think see what's happening. So the pendulum, I guess that would be my question for the group. Do you think the pendulum's going to swing back in our favor? I don't know. I mean, I look at him and I think perhaps.
That's actually what I was going to ask everyone is this is going to be fun. I wanted each of you to just give me one word. You can either choose pessimistic or optimistic about the future of healthcare. And I know that there's caveats and it depends, but let's go around and just, Dr. Baumgartel.
Sad to say, pessimistic.
Okay. Dr. Gantworker,
Pessimistic.
Hamilton,
Pessimistic.
Dr. Block,
Same, pessimistic.
Dr. Badia.
Pessimistic.
Wow. Okay. That's really powerful. I just want to pause for a second and let the audience, whether you're watching or listening, I just want you to like digest what you just saw or heard. Like 5 out of 5 doctors just said pessimistic when asked if they're pessimistic or optimistic about the future of healthcare. Wow. If that doesn't scream, we need change, I don't know what does. So some food for thought for those of you listening. Okay.
Well, can I ask why the pessimism? Like why each of us are pessimistic?
Yeah.
Do we have another hour?
I can start. Part of the problem has been the rise of the physician administrator class. And sorry to say, we've seen the enemy and it is us. We have a lot of physicians who've climbed their way to the top and sort of, and this is not to indemnify or condemn all of them, but I remember about 10 years ago when macro MIPS was really getting revved up and we had certain people in my field who sort of jumped ship and ended up joining the administrative class and began to browbeat all of us, and there are still there saying that, and these are most people who are close to retirement or about to transition, want to slow down, and they want to be administrator and get paid a lot more money and get to sort of mistreat their colleagues. They would not look at anything with a jaundiced eye. Everything was just sort of spoon-fed for them, and they were given marching orders, and they all too easily carried them out. And now that we're seeing macro MIPS didn't make any difference, they still won't do a study to show whether or not macro MIPS made any difference. They have the largest cohort of patients in the universe, and they won't turn, and the Medicare has yet to write any papers that macro MIPS made patients any better, saved any lives, or improved quality of care, because they know it didn't. And all these guys and girls, people who jumped to this administrator class and sort of beat us, saying that we're not making our quota, we're not checking this box, checking that box, have all been part of this farcical, non-funded dictum to us. And they've really, I think they share a lot of the blame of what's going on. But ultimately, also, we have not been able to organize ourselves properly. And Dr. I think Alejandro mentioned unions. There's also things called guilds, which I'm a big fan of, and I'm working on right now to form a kind of physician's guild where it's not a third party. So it's not AFL-CIO or SEIU. It's actually you elect your own representatives, much like Directors Guild, Writers Guild, SAG-AFTRA, and you actually elect your own people. And it's actually not a bad thing. And hopefully we'll stop calling everything socialism that we don't like and just realize that whether we like it or not, we have to we're going to have to jump in the boats with each other. Otherwise, we're all going to get flipped over and tossed in with the sharks again.
Well, that makes me optimistic.
We'll be right back. SoMeDocs is building a conference called Empowering Women in the Face of Cancer, Navigating the Path Forward. Take a listen to some of our speakers.
In this lecture, I plan to help you with Oncology 101. I will be discussing the different types of tumors, different types of treatments, staging systems, as well as how to organize yourself.
In my talk, I will discuss what the latest research is on the Disabilities Act, as well as what protections you have for your career, and why you may want to work, and say that out loud and share that with others.
For many patients, it becomes a really difficult landscape to navigate because there's just so much conflicting and contradictory information out there about all things non-conventional and holistic approaches.
I look forward to providing you with what I didn't have and what I wish I would have had when my family member was battling cancer.
am excited to bring my years of experience to this forum where we'll get an opportunity to talk about how to empower women with cancer diagnoses through a mental health lens. What we know from research is women that do focus on their mental health priorities and make it a priority during their cancer treatment tend to have better health outcomes.
I work with people who have trauma and triggers, pretty much negative life events that seem to show up when they're not invited. I look forward to sharing with you how you can address these triggers and these memories and integrate them so that your body no longer has to try to protect you and remind you of these difficult moments you've been through, but so that you can process them and release them and go forward in a different way.
I'm Dr. Sunny Miles, and I practice palliative and integrative medicine. I'm passionate about helping people navigate these challenges, helping people feel more resilient, and helping people identify and live what matters most to them, even while they're going through treatment.
It's crucial to discern between inherited and sporadic cancer, to understand what cancers can be inherited, what is a mutation, what is genetic testing, and to separate fact from fiction, especially in the day of social media.
In this presentation, I'll be drawing on my years of clinical experience as an art therapist, working bedside at Memorial Sloan Kettering Cancer Center with female oncology patients and their families, caregivers, and providers, and explore the many ways that art can help heal and empower patients, reinstill a sense of hope, calm, and mastery, and eventually lead to better patient outcomes.
You can catch this event live and watch all of our lectures for free, May 13th through 18th, 2024. Otherwise, access the footage on our website at doctorsonsocialmedia.com/conferences. Now back to the show.
Well, that makes me optimistic. No, I'm totally serious. I'm totally serious. Like you're coming up with strategies to get us out of this mess. That's optimistic.
I've been talking. I can share with you a piece. I've wrote several pieces on this, and nobody seems to give a crap. But I'm hoping that some people will give a crap. I'm finally getting some attention and some traction on them.
Listen, the same thing happened with unions. Like someone at some point did it, and now it's working, and it's happening. It's infectious. It's happening in other places. That's cause for optimism.
It's true, and I'm just going to stop talking after this. But there are certain physicians who still think that it's going to drive the cost of care up even higher. And my argument is, well, nothing's slowing it down. So I'm not sure how physicians sort of drawing the line in the sand is going to drive up the cost of care, other than not being mistreated anymore, not being on the verge of suicide, or leaving the practice of medicine entirely. I don't see how that could drive. And if it drives up the cost of care, I say alia jacta est. Let's cross the Rubicon and do it, because I don't feel like nothing else is working, quite frankly. So stay tuned.
Who else wants to weigh in?
Well, I want to follow on the guild. I love that. And by the way, physicians can unionize. One of the people on my podcast, and I discussed this with Dana, but she knows a lot about this. The person I mentioned before is named Julio Gonzalez. He's actually an attorney, an orthopedic surgeon. He was a state representative, ran for Congress, lost to a trial attorney, of course. And he's on the board of directors of something called the U.S. Medical Association. So it's basically so Brian's nodding his head. He probably has heard of it, knowing Brian.
Sure have.
But Brian, I don't see any traction with this, and I blame myself as well. I told Julio I'm here to help you, but I know Julio's still doing I don't know how many total joints a week, and that's the problem. Is that in the end we put our patients first. Right, I think Susan said that, and the reality is that we have been bred to be competitive and oftentimes not collaborative. It all started sophomore year in organic chemistry, and we've never moved forward from that. And everybody knows that and is laughing their way to the bank, knowing that whether it be your hospital administrator, the insurance industry, what have you. So my pessimism comes from a combination of too many middlemen, and they found a way to kind of squeeze us out, and the fact that we don't collaborate. And I see that at a micro level with very good colleagues, people I would consider friends, but I can't make a positive change. So, I don't know if it's going to take a Mahatma Gandhi of medicine. We must do this without violence, but It's going to take somebody super charismatic. I don't know.
Well, it strikes me listening to all of this, which is fascinating, and I don't disagree. This is good stuff. But we are speaking of ourselves as physicians, of course. I think what's happening, it's like a parallel universe, the metaverse here, is that the general public, patients, some of them are not educated, some of them are highly educated, but everyone together is kind of, there's been a dumbing down of our profession such that they don't expect care from a physician anymore. In fact, they maybe don't even know the difference between a physician and their chiropractor, and they're gone to their chiropractor for treatment of their leukemia, which is now, whatever stage, like, ay. And so, this whole word provider, don't get me started on that, I'll probably throw up, but this kind of the bastardization, this kind of neutral, everyone's the same color, no one's different, and it's like a putting the wool over, the sheep's head, or whatever that phrase is. Unfortunately, patients don't know whom they're getting care from. And I think that is probably one of the most egregious, scary things that's happening while we all debate how we can be better physicians and be of better service. And that's like the horse has left the barn here. And so that, unfortunately, is going to taint everything that we were just talking about.
Okay, so on that note, let's move on to the next post.
Hey everyone, so we're going to do a quick outfit of the day. So first we have our gown, so business in the front, party in the back, very versatile. Then we have a couture bag from the French designer Normal Celine. We have the socks that are 99% cotton, 1% C. diff. And then to top it off, we have a unique bracelet that's a one of one. I personalized mine with my name, my birthday, and a special number for those who know. Thank you.
I needed to get your reaction to that, because I couldn't stop laughing when I saw that. Yeah, there's not really even a question. I mean, did you notice the couture designer name?
Normal Celine.
Yeah, Normal
Celine.
Celine.
I noticed that we didn't exactly see the back view.
You were hoping. I'm sorry, it was disappointing.
Yeah. So anyway, there's really nothing to say unless someone wants to chime in with their own designer name. I mean, how funny is that?
I haven't stopped laughing.
Yeah, it's funny. Doctors are some funny people, funny humans. So, okay. That was another one that just always cracks me up. Okay. Yeah.
Why do we do this to patients though? When you think about it, I mean, I understand if you're gonna, have a Whipple procedure, you kind of dress that way. But with stuff that we do, why can't people just wear, comfortable clothes or pajamas and have, IV access? And I've never understood that.
Well, I'm assuming it
and
has to do with hygiene, right?
Yeah.
But-
So for my surgeries, they can wear yesterday's clothes and it would be totally fine. So,
well, you guys wash your hands after surgery.
Exactly. I wear gowns to protect myself. But for your surgeries, Alejandro, there really needs to be a sterile field. And so if they were to wear just regular clothes for hand surgery, would there be any concern of sterility there? I mean,
well, let's talk about that. As the folks who are taking a bigger piece of our pie, there's a big pushback, at least in hand surgery. It's probably the area of orthopedics where we best can get away with in-office surgery. So as my surgery center, which now is bought by mega corporation, half of it, my procedure room, and I wouldn't put them into anything. They roll up their sleeve. And I can do, a trigger finger. I can do a simple fracture. I can do all these things where they don't have to change into anything.
Great.
So, and I think we're going to see more and more of that. And I mean, I would imagine in your field, there's a lot that can be done.
People are doing more sinus surgery in the office. We're doing more stuff in the office than the operating. Ear tubes now are going to become a thing that can be done in a select population. In children. In adults, we already do them in the office, but in kids. So yes, that stuff is happening. We're taking cues from the oral surgeons. We're getting it out of, and this is a way that we're wresting control from them and back into us. Yeah. Optimism.
We can do some lumps and bumps like from a general surgery, and I've even done like skin removals, but obviously for belly and
Skin
they've got to be
removals?
gown.
Why are we removing
Like
skin?
like excess skin. I've
Oh.
done that in the office. With
Whoa.
I mean, I have I have a little small surgery suite, but outside of that, obviously for belly and probably brain and spine, they have to be like sterile in an OR.
Well, we do. Some people do
Heart, chest, a whole bunch of other organs.
Some people do kyphoplasties in the office, and you actually get paid a butt ton of money to do it, but you have to have like a laminar flow room, you have to have a lead lined room, so the cost is, you have to have a fluoro. I mean, it's really expensive, and I've never wanted to bite of that apple because all it takes is one cement extravasation into the epidural space, and I'm, not going to ever do it again. So I figured why even start. But yeah, I mean, I do shunt taps, LPs, obviously, that kind of stuff we can do. You just have a sterile field. But yeah, some things like small debridement, like if you have a patient with like little skin stuff, like I have the packs and stuff, and we keep them up to date. And God forbid I have to take a culture and stuff like that, or probe a wound, which I thankfully don't have to very often. Yeah, that's definitely in office. And I actually try really, really hard, by the way, if I do have a post-op wound issue, which I rarely do, but when everybody does, I really try as hard as hell to not send them to the emergency room. Like if there's any way I can manage it at home, not at home, manage it in the office, have them come back the day after tomorrow. Hey, can you come back Thursday? It's Tuesday. Most of the time I can keep them out of the hospital, which I don't know if the hospital cares or appreciates, but I certainly don't like going to the ER and having to deal with that nonsense. So yeah, I think we should do a lot of stuff in the office. I think preventive stuff, like you're doing some excess skin removal. I mean, trigger fingers, that's awesome. I think that's great. I think I should do sinus surgery in the office.
There's
no
a
reason
dark
not to.
side though. There's a dark side to that, in that there's something called balloon sinuplasty, where you put a catheter and you put it into the sinus and then you balloon it open. And so because it's done in the office and not the operating room, they view it as an alternative to the operating room. So now you're saving the insurance company so much money that it is highly reimbursed. Well, that's a huge incentive to do it. So now you've got these practices that are like balloon mills, where they're ballooning mostly headaches, which are typically migraines. So you're not actually doing anything, even though the patient typically feels pressure in their sinuses. They're convinced that their sinuses, it's normally not from the sinuses. And yet you advertise to these people, they come to your office in droves, you balloon their sinuses and you make bank. So there's a dark side to also taking this stuff out of the operating room and bringing it to the office, as I guess with all things.
Well, Dana, I wish you had a psychiatrist in our panel, because there was a major Freudian slip here with Brian about surgery at home. And I'm starting to think about it.
Robotic.
Right? The hospital at home, right? Zeev Neuwirth talks a lot about this. And
that's not a new thing though, Alejandro, that's not a new thing. I mean, you go to a lot of rural medicine, you had a family doctor, like in these small towns, they would have the office be in the back of the house in the porch, and patients come in and have minor procedures done. I mean, there are even stories of guys doing appendectomies in their back office there. I mean, so.
Or we go way back in time.
Yeah.
My grandfather was a veterinarian. He did stuff in the kitchen.
I mean, back in the day, Richter Horsley, one of the fathers of neurosurgery, was doing retro SIGs in patients' parlors. I mean, not that that's great, but I mean, that's, how he would do surgery, kill some people in their homes, but that's actually, I mean, done right, you could totally have a home office surgery center. I mean, that's what they used to do back in the day without the added advantage of, fluoro and stuff like that. I mean, that's not totally crazy. So maybe it wasn't a Freudian slip.
But I think home hospital, he means, is their own home, right? That's when people are discharged to their own home.
Yeah, that too. Yeah, but they did it both ways. They would, he'd go to their home in their own parlor, or they, a lot of, I'm sure we have relatives or know stories of people who are family medicine doctors who do minor surgeries in their office that's in the back of their house, So I don't know.
Brian, as long as you move to, what is it, trephination, or what is it?
We've done.
Just don't go that far.
There was a push for us to be able to do trephinations in the field, like kids getting hit by softballs and getting epidural hematomas. And like there was talk even at one point we should have trephination kits in baseball fields and stuff like that to be able to like do a burr hole. Not that it's going to be great, because usually the acute blood's so gummy and like currant jelly, it's sticky. You can't. I mean, you can sometimes if you're lucky, but the blood is like, it's like trying to suck jam through a straw. It doesn't work. So yeah, but let's not do that. Let's not go there.
We do have
Let's
home
not do that.
births now, so not that
Yeah.
not that I'm advocating for them, but I'm just saying.
Right.
Just throwing.
Fast.
All right, here we go. Let's do the next one. And it actually fits in with what we just spoke about. So here it is. I'm going to show it again.
Show it again, please.
I'll do it one more time because you can't see the first thing. I'll read it to you after. How many layers can you remove and it's still you? Is that what it said? Hold on.
I think it says until it's still you. I'm not sure that.
Let's ask it again. Let's see.
Let's see.
No, until you're still you. How many layers can you remove until you're still you?
Do
I
they
feel
mean
like
and still be you? I think that's
yeah,
what they-
exactly. That's definitely what they mean. First of all, I thought it was so interesting to show that right after Dr. Hamilton was just talking about removing skin. But I don't know. I just felt like that's such an interesting. I mean, does anybody just have like a knee-jerk reaction to that? I know how I interpret that, and especially where it comes to medicine.
I think as a woman in medicine, and I happen to be a wife, I happen to be a mother, I happen to be a creative artist kind of person. I have all these different layers and different facets of me. And, I think about what we bring into the exam room, what the patients see us. Do we have we have a persona, we're physicians, but sometimes peeling back those layers, people are hurting because, their loved one has just died. Well, I'm a human being too. And, I've had 3 people die. And so I can share in that grief. I can understand that grief, or peel back another layer, and so, yeah, I'm a mom and this is what's happening to my daughter, et cetera, et cetera. So I think those are layers to all of us as humans. And maybe the question is, do physicians have an additional layer? And is it there for a reason to keep us tough, to protect us? Or is it to separate that doctor-patient relationship because we're not their best friends or their buddies? We're caring for them in a different way. And so there's a lot of that going through my mind right now.
So
Yeah.
I took it a little bit different. I took it, and maybe I was thinking about either residency or kind of the current state of medicine where I come one way, right? And it's like, they're like, do this, do that, do that. And it's like, okay, how many like layers can you take away before I feel like I'm now a robot and I'm not Dr. Hamilton anymore, with all this innovation. And so I think, surgery residency was very tough. And we've talked about this in the first episode. And I was like, when that came, I think had nose rings, earrings, hairpin, and my chairman like made me like, you know what I'm saying? I became this like, I look a lot different doctor than I did back then. And it's like almost to the point where, I mean, obviously I needed to mature, but I was like, well, how much of this are you going to like take away? You know what I'm saying? I like red or blue, or you know what I'm saying, wanting to dye my hair different colors. Since then, I have like not done that anymore, but it was very much, you're a surgeon. This is how surgeons act. This is how you're going to be moving forward. And so that's kind of how I took it. Like, how many layers can they remove and it's still you? And I apply that to today's medicine too. Like in the hospital setting, there's so many like pre-filled orders and all of these things, that all these like check boxes that you have to do. Some of it has been helpful, but some of this is like, this is a waste. Like, I wouldn't have done any of this. You know what I'm saying? Like, if I had, which is why I chose to go into private practice, because I felt like I could have a little bit more control on how I wanted to treat the patient versus in some employed models, they have like this outline of how you should treat the patient based on these guidelines. And I feel like that was taking too much of me and how away, and how I wanted to treat the patient. So that's kind of the way I saw, like, how many layers can you take away before you're still you, or are you just a robot now doing, or a puppet doing what they say you should do? So that's the way I took it.
I'll go next, I think. There's a couple ways I look at this. The first is a little bit like Franchelle mentioned, neurosurgical residency is sort of like a trial by fire. You sort of go in one way and their goal is to beat you down as much as they possibly can. And then hopefully from that sort of forge something stronger. And One of the reasons I did get in a little bit of trouble during residency was because I refused to be beaten down. As I wanted to still be me at the end of the 7 years. And my wife tells me this too. It's like you just went in with a chip on your shoulder. It wasn't so much a chip. It was just sort of like not wanting to become this heartless dickhead, basically. And I refused to do that. And I just remember, there were some tough times, and I disagreed with my attendings. I questioned them, and I have zero regrets. And I just remember sort of leaving the hospital, the sort of offices, after I handed in my ID badge and everything. Like the last day, we're leaving for Arizona in 2 days, and I just sort of collapsed on my knees. I just exhaled. It's just like the air went out of me, and I just started sobbing because it had been so hard, because I had held on for so long to that little nugget of me that's me, for 7 straight years of nonstop BS, basically. And I love my program. I'm very grateful, but there were parts of it that just were not necessary. And that was one of the things, like, to drive the humanity out of you, to make you think and do what they do just because it's what they do. And if you question it, you weren't really looked upon kindly. And so what I do in my practice now, I connect to people on a human level, uncomfortable, not uncomfortable, weird human level, but I kind of just on a human being level, and try not to sort of be so much aloof. And you have to be aloof to some extent, otherwise you become just so raw, like a scab. You can't deal with it. But having a safe sort of distance with you and the patient, but just sort of connecting them on a much deeper level, and sort of like injecting humor into stuff and making jokes when it's appropriate, and sort of laughing and enjoying each other's company with my patients is sort of what makes me happy, because I know not a lot of other people do that. And whether or not I do their operation is almost irrelevant. It's like, if I've connected with them and I make them feel comfortable, if they go with somebody else, then that's fine too. I walk out of there very, very comfortable, thinking I've given it my all, I've done my very best, and treated them like family. And ultimately, that's what I want to keep doing, and what I refused to give into during my residency. And it did cause me a lot of pain and suffering, but I have no regrets about it, none.
There was a post recently by a neurosurgeon who has a lot of followers on Instagram, Betsy Grunch, about her, she was given a packet at the beginning of residency about like swimming with sharks. This is what residency going to be. If there's blood in the water, get away from there, because, that's when the sharks come in and attack, and don't let them see you bleed. Otherwise they're going to come and attack. Like, that was given to them at the beginning of residency, because that's what the expectation should be. That's insane that they were like, we're just going to let you know, this is how toxic our program is. Like, they just had a pamphlet on dealing with it. That is just
so the
nuts.
The CNS actually has the meeting is coming up in Houston, where I'm giving a couple talks, has a panel about swimming with sharks, about residency. And I'm not sure that's something we should really celebrate, but I think you're right, Brad. It's kind of crazy that's a thing. And it really is kind of like Lord of the Flies during residency. It really is. You're sort of climbing over each other, trying to get into the good graces of the attending, so you don't get pimped. Or when you get pimped and you get it wrong, they're not going to think that you don't know what you're doing. Because if you're not, and the spotlight's on you in the bad way, ask anybody who's been in that spotlight where they don't want to be. It's a very uncomfortable place to be. And you are the middle of all that water, blood in the water, and chum, and you are the bait. So yeah, it's terrible. It really is. And it's part of what's, I think, drives us apart ultimately. Like Alejandro was saying, we're so busy trying to screw each other over. I mean, that's kind of starts in residency from a very early age, but also it does start in, sophomore year organic chemistry or biochemistry.
We'll be right back. Private Practice 101 is the latest in virtual conferences you can access on our site.
I'm going to talk to you about lease negotiations and purchase negotiations.
I'll talk about how to prepare, plan, and organize your personal finances when you are starting out on your own private practice.
We're going to talk about how to apply this information to detect and prevent fraud.
This talk is for doctors who are fed up with the overregulation of patient care.
And I'm excited to teach you the ins and outs of how to build a thriving referral network and Facebook group.
And how to build in compliance efforts and strengthen your negotiation tactics. Because I want you to make money and I want you to stay safe.
I'm really looking forward to talking with you about creating and retaining a high-functioning team.
About the psychological and emotional things that undoubtedly come up
as you reach certain barriers.
Marketing yourself as a professional in the world of today.
Form a virtual corporation and use your practice skills in a virtual environment that allows you to thrive without having to worry about managing overhead, managing a staff, or even managing a building.
Top mistakes in credentialing and those key metrics you're going to want to monitor in order to increase your revenue in your practice.
How to overcome your fear and move from your medical practice now into a private practice.
I'll share 3 distinct skills that when you use them, you can create and maintain a long-lasting, passionate marriage while becoming a very successful practice owner.
My talk called Creating a Vision and Applying It to Build Your Practice is going to help you streamline your process and create the practice of your dreams.
Stop trading the value you provide to patients for cost.
I'm going to teach you how to learn your value and your worth, how it is you get paid and what you actually cost, and how to train your sniffometer and know when to leave.
Access this valuable resource at doctorsonsocialmedia.com/conferences. Now back to the show.
Yeah, it's terrible. It really is. And it's part of what's, I think, drives us apart ultimately. Like Alejandro was saying, we're so busy trying to screw each other over. I mean, that's kind of starts in residency from a very early age, but also it does start in, sophomore year organic chemistry or biochemistry. In residency, it is magnified, transmogrified, multiplied. It is rough.
Really?
And I really wish, it's in our residencies, at least, I can't speak for everyone else, but neurosurgical residencies, at least used to be very much sort of like climbing to the top. And it could be kind of rough. And some people come out transformed. I really didn't want to be different with them when I went in, other than smarter and a good surgeon. That's really wanted to be, but I didn't want to be. The personality changes is what I refused to adopt.
See, I feel like we were a tripod, me and my 2 co-residents, because we each held each other up. And if one of us was not there, then the other 2 would have fallen.
Nope. That's not what happens usually. Not at least in our...
present perhaps be a little devil's advocate, because I've seen a little bit. I happen to be a surgical intern on the cardiac surgery service at NYU, which Brian, that was Ransohoff's program, and that was pretty toxic, right? But I will say, just like Navy SEALs, what they put them through, and there is something about resilience that comes out of that. And I agree that a lot of the more toxic stuff was unnecessary, but I worry a little bit about once a Bell Commission came in. And again, I happen to write about that in one of the early chapters in my book, and talk about how one of my co-residents was actually an ENT physician, Brad. And I'm not sure I ever met her, but she kind of blew the whistle to the New York Post. And I have that. I'd love, maybe I'll take a picture and send it to you guys. The New York Post says sleepless doctors, and it was like blasphemous. And they tried to change things right away as a knee-jerk reaction. But I remember my senior resident sent me home one morning because we had to go home after X hours. I go, wait a second, I'll stand in the corner. I just want to see this case. And guess what? I've never seen that case since.
Yeah.
That was and I knew that was an unusual case. I didn't get to see it because he made me go home. And that's the perspective I look at that from.
Have you ever seen that again?
What's that?
Have you seen that again? Like you didn't?
No, that's it. So I'll just be split. It's a total ankle replacement. It's not, they're more common now, but for whatever reason, I never saw that in the rest of my residency.
Well, I wasn't talking about hours restrictions. That's not what I'm meaning at all. I liked being up all night. I liked being able to function. That I'm not complaining about that. I'm talking about personality stuff. Yeah. I'm talking about the way they acted. I'm talking about, God bless Ransohoff. One of my attendings trained under him in neurosurgery at NYU. So I've heard Ransohoff stories, believe me. So he was kind of a unique guy, cigarette smoking, Harley riding, just an absolute wild man. And the way he broke news to a patient once was he decided to use the patient's bathroom. While he was peeing, he told the patient he had a glioblastoma. That's what I'm talking about. That's a Ransohoff thing. And so that it's funny. It's like, apocryphal, maybe, I don't know. But the guy had told me is pretty reliable and has been known to spin yarns, but he doesn't really lie or make stuff up. So I'm talking like, that's what I mean. Like, I don't mind being up all night or operating my ass off. excuse my language, that's fine. I need that. I need to be able to be strong. I need to be physically ready to do that. And that's why neurosurgery has one of the lower burnout rates, because we know we're going to get killed. We know we're going to get slaughtered. I'm just talking about ripping the humanity out of you. Now, I'm not talking about being sleepless. I'm talking about acting like a jerk. That's what I mean specifically. So I'm sorry if that came off that way. No, I like hard work. I love hard work, but it's not what I mean. I mean just the way you act around people, just keeping your humanity. I mean, you could be tired as hell, but be up all night and still act like a mensch, as our people say, like a human being. You know, that's what I mean. That's what I'm trying to say. Just acting like you have a soul still. You could be tired, but you can still have a soul. That's what I'm saying. I'm not talking about hours restrictions. I hope that's clear. I wasn't talking about that.
Yeah, I understood what you were.
Yeah. Okay. So let's do one, maybe squeeze another in, but I think maybe one more. Let's share the screen and watch this.
So we got the results back. So basically,
upgrade to Life Premium so you can hear your diagnosis sooner. And if you upgrade to our Life Extended package, we'll give you a real doctor who will actually try to help you. And with Life Extended Elite, we'll let you choose which disease you want, as long as it is equally or more severe than your current diagnosis.
you're fine. Just drink more water. That's going to be $800 for today's visit, by the way.
So I was laughing at that when I saw it, but the question is this where we're headed, just given the reality of AI and all of the machines, all of the screens? What kinds of practices do you each foresee healthcare professionals adopting to fit into how society functions and interacts today?
The $800 was absurd. Up until then, it was funny, but then to me, that was the irony: is the public watches that and thinks, right? So I think the public should know what Aetna reimburses for a level 4 consult.
No, that's what the EOB says. So then they think they're being charged $800, but really what we're getting is $1.50.
$34, no, 34 pesos.
Right, but when the public watches this and it's puzzled by it, but then right at the end you get that, and by the way, that'll be 800. That's the part that really I want to interject with, because that really got to me. Until then I was and but man, that's
I agree.
that's my
that's the way everybody feels, and I feel like that's the way people make physicians feel. And stuff like that gets like rotated on social media, and it's very frustrating because then you have patients coming in and oh, they only spoke with me for 15 minutes for $1,000. I'm paying all of this in insurance or whatever. And then patients start feeling some type of way against their provider because this stuff that's going around is false, and they joke like that, but for patients that's real, because you're right, they see the EOB, which is not what we actually get. And that's an insurance, and they don't really know how much insurance actually reimburses us, but they see these commercials and these things on how we're getting. I have patients saying, oh, you want to prescribe me this X medication so you can get a kickback. And I'm like, where are they getting this from? They just circulate these like lies. I'm taking them to this place so I can make more money, or prescribing this medication, as though I'm not doing what's in their best interest. And then yeah, so I think I agree. That was funny until the end, because I feel like in general, that's the way the physician is viewed. Like, we give you minimal information, but we want this astronomical fee in return. And that's just,
I think also, I agree exactly with what you just said. I think also people are willing to pay for things that are not healthcare related and plunk tons of money down. Like, okay, it's Sunday evening and your kitchen sink's exploded. Yeah, you don't mind forking out $800 for a plumber who's going to save your ass right now because your kitchen's flooding with water. Oh my God. But no, if you pay more than $20, which is your little flippity copay for someone who is just, put a stent in your coronary artery, like, oh my gosh, so I think there's just this disconnect between people will dump money for so many things, but the moment it comes to healthcare, oh no, it should be free, or why is this doctor so greedy? And I think that's such a sad condition.
Well, the system's kind of opaque. It's completely opaque, right? Because they never know how much they're going to pay. And we can't tell them how much they're going to pay because I don't know their insurance. I don't know if I know their insurance. I don't know where their deductible is. I don't know how much of their deductible has been met because it's such a dynamic process. I don't know the complexity of the visit. I don't know if I'm going to do any procedures. So they want to know what it's going to cost up front. And we can't tell them that because the system is just too complicated, which isn't our fault and isn't their fault either. It's just kind of the system that we're stuck with until someone innovates enough to get us out of this system. So I think it's, it stinks for them too when they roll in and they're like, how much is it going to be? And you're like, no idea.
But then they're
It's
mad at the
intentional.
physician,
It's
though.
completely
And that's
intentional.
the insurance problem. It's not the physician problem.
Right. So what I oftentimes get in arguments with healthcare policy wonks online. And it's very funny because these people are paid through these think tanks. And I use air quotes because they need to drill some air holes because their hypoxic ischemic injury is obvious. Because they go to Congress and they say, well, this is how much healthcare costs. And they'll report what we charge from our charge master, the invoice price, if you will, the sticker price, if you want to really get sort of basic. But the point is we get paid about a third of that. And so when they create these papers that they give to Congress to show how much healthcare is, they're actually assuming, and I've had one of them tell me this, that we get paid 80% of what we invoice. And that's what they base their calculations on.
What a joke.
So I went at one of these guys, and sure enough, some random wonk from a different think tank, from a libertarian think tank, came at me. And I just said, I gave him the Captain America gift. I can do this all day. Keep going because you're lying. You're in front of Congress lying to them. So this is where a lot of this, why we get stuck, why we can't air it out like an abscess, just open it up and let it, express outwards, because these guys keep giving this BS because these healthcare think tanks are really funded by insurance companies. If you start peeling the layers of the onion away, it's Blue Cross, it's Blue Shield, it's United Healthcare, and they fund them to write these papers to show to Congress that we make too much money. And if you look at the No Surprises Act, doctors are winning about 80% of those. And so the solution, the conclusion of one of these healthcare wonks was that, well, we need to pay doctors even less. It's like, well, wait, if the judge thinks, the arbitrators think that we're charging a reasonable price 80% of the time, sounds like you're not paying us enough, right? I mean, if we're winning, that means you're paying too little. So this is sort of the inverted, upside down way that they think that they give to Congress, and why we can't make any headway, because they keep lying to them because they're being paid by the insurance companies to lie. And so the patients think that, if I invoice $1,200, I'm getting that. But what's really funny though, and I'll stop with this. I've asked the wonks, what do you think a reasonable price for a craniotomy is? And just for those of you watching, obviously we take a piece of the head off, we suck something out, we put it back on, and the patient doesn't die. So I've asked them, do you think it's reasonable to charge $1,200 for that and get paid $1,200? And the line always goes either dead, or they say, well, no, we're not talking about that. It's like, but you are. See, so, I go to residency and fellowship, all these other things, to take off a piece of person's head, take out the blood clot, take out the brain tumor, not kill them, not paralyze them, put it back on, stitch it off. They don't get an infection, and they walk out of the hospital 4 days later, totally fine. They get back to their lives. What is that worth? And they won't talk about it because they realize it's not worth $1,200. It's worth a hell of a lot more than that. And so when people say, well, doctors make too much money, it's like, well, take a look at the CEO payment of the health insurance plan. Why should they be making $25 million plus benefits?
Plus 90 days, Brian. 90 days.
Right.
You're
Exactly.
responsible.
I was going to say that 1,200. Don't forget that includes everything in
Right.
between.
So
if you have to
this
take
is
it
where we
back-
lose. This is where we lose the script, right? This is when things go off the rails, because when you ask them the question, the important question is, what is me taking the brain tumor out or the blood clot out that's threatening this person's life worth? They will not answer the question because they know it's worth a hell of a lot more than fixing someone's bumper.
And
that's when they go
slippery, and that's a slippery slope, because then you talk about, from my perspective, a cognitive specialty, right? Internal medicine. I'm not doing surgery on people. And, was it worth for me to spend 40 minutes listening to someone talk about
a lot of money,
their fatigue,
a lot of money,
their fatigue that is multifactorial?
I think it's worth. Yeah,
and
I think it's not just
wave our wand and say this is why you're fatigued, and oh boy, maybe there's depression, and maybe there's the medication management problem, and maybe you're in the menopause, and all those things. 40 minutes later, we're lucky if
It's
we get
cognitively intense.
18 cents on that visit.
Yeah,
Right?
we're not talking about just work, like physical, me doing the physical work. We're also talking about you caring about the patient, thinking about the differential, generating a diagnosis, ordering the damn tests, interpreting it, calling them, saying, "Hey, we need to do this." Following them
Susan,
up.
I've got a better one for you.
All these
advanced directives. How much should how much should you be paid for talking to people, having a very difficult conversation about advanced directives? Because we can quantify that, because we can tell how much it saves the system. And that should be a ton of money to
100%.
make sure that all of your patients have up-to-date advanced directives. So
100%.
this is very, very quantifiable information. And if we were able to do it, we could, oh my goodness, the amount that you could rake in from that. But that's, to Brian's point, that's just not how the system works. And that's where my pessimism comes from, because we're fighting the giant pockets of the hospital systems, of the insurance companies, of the trial lawyers. And all of us are saying, oh, we're doing it in the best interest of the patient, and then raking it in and raking it in. Meanwhile, chipping away at our income year after year after year after year with no adjustment for inflation. In fact, the opposite.
Yeah.
Never.
Yeah.
There's never been an adjustment for inflation in Medicare payments, just so our listeners and watchers know. In the years of Medicare, there's never been what's called an inflation adjustment ratio, an IR. There's never been one. There's never been one for the cost of doing business as it goes up. There's never been one.
And we just got pay cuts, like
Yes.
Again.
Again.
Yeah.
Exactly.
Correct.
We just got pay cuts.
Correct.
Like in
Correct.
our current inflated,
Yep. Yep.
Well, I think this is going to be the point where we end this, not only this episode, but it's the final episode of our program, The Five, right? It's been such an amazing journey. I know that there have been a few others that are involved, but I'd like to thank everybody here for joining us. It has been a hoot, for lack of a better term, just thinking back to like the entertaining posts, of course, some incredible discussion that's, I think, is going to really stimulate others and make us all think and hopefully eventually change. Because again, to just bring up that 5 out of 5 are pessimistic ratio, like stat, I'll say, it makes me sad. And so I'm ending with an optimistic goodbye. I'm hoping that all of you are happy in your jobs and maybe impact change in the ways that each of you is doing it. Aw, how cute is that?
Oh, that's a good
This
way
is
to
what
end
makes
it.
me optimistic right here.
I love that. Yeah, our family, your furry child, and all of our families. At the end of the day, that's what we come home to and we love. But thank you guys all for joining us. And thank you all for listening and for watching this show as well. Bye-bye.
Thank you.
Thanks so much for listening.